Hello and welcome to this episode of Let's Talk About by Kangaroo Minds. I'm Vedika and today we have with us Dr. Rajesh Parikh. Dr. Parikh is the Director of Medical Research as well as the Honorary Neuropsychiatrist at the Jaslok Hospital and Research Center. He's an Adjunct Professor of Psychiatry at the University of Iowa and a former WHO expert on depression. He has been invited to lecture at the Harvard Medical School, the Johns Hopkins School of Medicine, the Yale University School of Medicine, and the Institute of Research in Neuroscience and Neuropsychiatry in France. Along with this, he has delivered over 125 international lectures and has an equal number of publications in both national and international journals. Dr. Parikh has a distinguished academic record and has won several awards for both his academic work as well as his interests. In 2021, he published 2 books on the coronavirus pandemic as well as on the vaccination drives. And a lot of the forecasts that he made in that book based on scientific research have already come true. He is also a well-known voice on the pandemic. Today, we're going to talk to Dr. Parikh about how we can rethink and relook at mental health and mental illnesses. However, before we begin our conversation, I would like to put out a trigger warning for our audiences. If at any point during this conversation, should you find yourself feeling triggered or distressed, we urge you to take a step back and look after yourself. Should you need any additional support resources, you can also find them on our website. And now, without taking up much time, let's hear more from Dr. Parikh. Dr. Parikh, welcome to the episode. It's so lovely to have you with us today.
Thank you, Vedika. Lovely to be with you. Thank you for that generous introduction. I hope I can live up to it. Thank you for having me on Kangaroo Minds. You are doing remarkable work, and I am more than pleased to support it in whatever way I can. And of course, thank you for that trigger warning. I guess it's equally applicable to me. So I shall do my best not to distress people in the course of this conversation. So let's go.
I really appreciate, all your time and all the work that you've done. You've been such an inspiration, Dr. Parikh, and, to have you with us today, to have such an important conversation. I think we're going to learn a lot from you.
Let's hope so.
I'm sure. So just to start off, I'm going to ask you something. I'm sure a lot of people ask you this, but, to set the conversation, since we're going to talk a lot about how we can relook at mental illnesses as well as mental health. So how would you sort of distinguish the brain from the mind?
Well, that's a deeply personal and philosophical question. It's a question that people have wrestled with for centuries, literally going back to René Descartes, and of course, Freud, and before Freud, Kraepelin, and a lot of philosophers, whether it's Sartre, Karl Popper. So it kind of transcends various disciplines. Somebody, of course, summarized it jocularly, because the debate is not entirely solved, by saying that, what is mind? It does not matter. What is matter? Never mind. So actually, over 10,000 years ago, perhaps even a little longer than that, it was assumed that a lot of mental disorders arose in the brain. But it was assumed that spirits had entered the brain and caused these mental disorders. And the cure for that was a process called trepanation, in which they drilled holes into the skull. But, skulls have been found which show these holes, and presumed that that was to cure mental illness. But moving forwards, people like Kraepelin believed that mental illnesses were rooted firmly in the brain. Freud, of course, changed all that with his work in the early part of the last century, or the century before, outlining the subconscious mind and the conscious mind, and talking about the id and the ego and the superego. And that was the dominating force, almost taking on religious fervor in academic circles for a long time. And then again, with the advent of neuropsychiatry in the 80s, we are able to understand a lot of mental disorders as originating in brain function, in the structure of the brain, the biochemistry of the brain, the physiology of the blood flow of the brain. And that is now the prevalent notion. I am blessed to be a part of this field. from its modern inception onwards. And this is known as neuropsychiatry.
Right. You've been a very, one of the early neuropsychiatrists in India as well. But, we'll come to talking more about, the brain part. But, what are your thoughts around, the notion that, we still look at poor mental health or, mental disorders as being a character flaw or a personal weakness?
Well, that is the biggest myth going around. In fact, the United Kingdom had a campaign almost 40 years ago, I think, which was called depression, an illness, not a weakness. So if somebody gets the flu or somebody gets malaria or even COVID-19, to talk of a current illness, we don't blame the person. We don't say that this person is weak, unless the person has been reckless, been walking around without a mask and has been anti-vaxxer, then perhaps some people might say you had it coming. But in general, when we look at physical illnesses, we don't see them as flaws in character. And unless we clear that perception, and you're doing a commendable job in that area, we will put a double burden on people who are mentally ill, the burden of the illness, the burden of self-blame, and added to that, of course, is the stigma and not seeking help.
Right. You've looked a lot at, like from a neuropsychiatry perspective, like looking at mental disorders from both a biological as well as a neurological perspective. So, why do you feel that it is important to do that and, like have conversations around that aspect of mental health and mental illness?
Oh, I think it is very important because we are then letting people understand that if somebody is depressed, it's not a character flaw. There is an issue in the basic functioning of the brain, the physiology of the brain, perhaps the biochemistry of the brain. And more important, it is correctable, that it can be treated. And when we start looking at mental disorders, the same way we look at diabetes or heart disease or even the flu, we will be able to approach them with greater empathy and help destigmatize these disorders.
So, it's almost in that sense, are you suggesting that we somewhere start looking at mental disorders as, brain disorders and not sort of associate them with a person's character or personality almost?
Oh, absolutely. But on the other hand, I'm not suggesting in any way that they're exclusively brain disorders. They are social disorders. There are other issues, environmental issues at play. Pollution lately is contributing in a strange way to mental disorders, and so is the pandemic and the isolation of the pandemic. So this is not in any way to emphasize that these are purely brain disorders, but yes, as opposed to character disorders, if you're making that dichotomy, then certainly the evidence is compellingly in favor of cerebral disorders, of brain disorders.
So it's very interesting, that you said that because, we've all heard the stigma around mental health and mental illness that, it's all in your head. So it's almost like you're suggesting it quite literally to a large, percentage is very much a brain thing and it is very much in our head. But you also pointed out about COVID, and I know you've written a book about this as well, and you've researched on, like past, not just COVID, but looking at other pandemics such as the Spanish flu. So how do you feel that, COVID has sort of changed our brains, especially, and what has been the mental health impact that it's had on people, both, who've gone through the pandemic, but also who suffered COVID themselves?
Well, the latter half of your question is easy to answer because the evidence is there. The first half, that how has COVID changed the brain, I think we're still struggling to understand it. But we do have precedents which can help us in an analogous manner, perhaps, to understand what is going on currently, somewhat better, if not fully. So, when the Spanish influenza pandemic took place 100 years ago, following the pandemic, and there were a large number of deaths, by the way, over 100 million people died in that pandemic. And when they did autopsies on the brains of people who had died 30 years ago, they found that some of these people who had depression, obsessive compulsive disorder, and Parkinson's had actually structural disorders and physiological disorders in a part of the brain known as the basal ganglia, which is integral to controlling. It's like a relay station. So the basal ganglia control our mood, some of our movements, and even our behavior. And actually that gave an impetus to neuropsychiatry, because now it was seen that illnesses which, say, Freud believed to be as a result of childhood or developmental disorders actually had correlates in the brain. And now we are beginning to see similar changes in the brains of people who have had COVID-19. In fact, some people who have COVID-19 begin with neurological or psychiatric symptoms. It's easy to understand because the pathway to the brain is shortest through the eyes and through the nostrils. And COVID primarily enters through the nostrils, and it has a much shorter cut to the brain than it does to the lungs. So we are seeing it happen, and there are correlates, because today one doesn't necessarily have to do autopsies. We have very powerful tools which look into the brain. MRI scanning, PET, positron emission tomography scanning, which is like a scan which looks at the actual functioning of the brain in real time. So they are indicating. I've had a couple of patients who've had severe mental disorders following COVID-19. So exactly how it occurs, we've not fully understood. But that it does cause a tremendous impact on mental health, or the data is overwhelming from all over the world. Whether you look at depression, whether you look at anxiety, whether you look at OCD, all of these numbers have climbed very quickly through the pandemic. And of course, then there's the social isolation, which is a stress in its own account.
So that, a lot of patients, I'm sure you would have also seen, are also struggling with psychosis. And I think they did some research around that as well, right? That post-COVID, I think patients are showing signs of psychosis, or they're hallucinating, and that could partly be linked to the isolation that comes, during quarantining as well.
Absolutely, it could be the isolation. And I think, we have to train ourselves, Vedika, to not look at things too simplistically. Because as was once said, oversimplification is the cardinal intellectual sin. So it may be a combination of the isolation and the virus.
Right.
And that could be a potent combination. And I've had patients who have gone unbelievably psychotic. A woman who wanted to assault her grandchild of 2 years because she felt that this grandchild would kill her. And she'd only tested positive. She didn't even have physical symptoms. She only had neuropsychiatric symptoms, and they are lingering now for 6-8 months. She was about 80% better, but it's been a struggle of the last 8 months to get her there.
Right. So I think, you also mentioned about, brain scans and brain imaging, and you spoke briefly about, MRIs and PET scans. So in a mental health context, can you tell us a little bit about, the insights that you could draw from these scans now?
Oh, all right. So, in the mid-80s, the Johns Hopkins School of Medicine started a neuropsychiatry program. I was fortunate to be the second inductee in the world in that program. And there I got to work under a brilliant pioneering neuropsychiatrist called Dr. Robert G. Robinson. And what he did was very interesting and intellectually very stimulating. If we were to study how different parts of the brain affect our mood or our behavior, we would see what happens when that part doesn't function. Because if that part is dysfunctional, you can correlate it with whatever change occurs in thought, mood, or behavior. And the best model of that was strokes. People who had naturally occurring brain strokes. So he started work on post-stroke mood disorders, and I joined in the very beginning. And what we found in a nutshell, because that's a lifetime's work, so I could go on and on. But what we found in a nutshell, for example, in depression, that people who had stroke to the left part of brain were more inclined to be depressed than those who had on the right side, regardless of their handedness. And the more proximal, the more forward that stroke was to the frontal part of the brain, the severer the depression. So we found two areas, the basal ganglia, which I alluded to when we were talking about the Spanish influenza, and depression in the frontal as a result of frontal strokes. And then, of course, we did a series of PET scans and saw how this evolves over a period of 2 years. That to me, was my start in neuropsychiatry, and I've been in that field now, for since 85, so just calculate the years, a little short of 40. But it's a fascinating field, and it's grown exponentially since these pioneering studies that we did.
Right. Another aspect of mental health and, mental illness, which is very commonly debated, is, the nature versus nurture debate that comes up. Is this, and I know we briefly touched upon it in the beginning, that, there is a biological genetic basis, but there's also a whole psychosocial aspect to mental health and mental illnesses. So could you throw a little bit of light on, the two sides of that conversation?
Yes. There is a joke which rather there are two kinds of people. Those who classify things into two kinds and those who don't. Well, I'm in the latter category. While it's useful to classify, of course, it helps our understanding. But at the end of the day, it's a simplification.
Yes.
So there needn't be the nature versus nurture debate. I mean, we know from our experience in life that nature and nurture are working hand in hand. They do so in our normal life.
Right.
Noam Chomsky's work indicates that there may be some programming for language, but our intonation, the way we speak, our amazing accents, even in the English language across the world, they nurture. So a lot of our behavior is a combination of nature and nurture. And so it should not be astonishing that some of our mental illnesses also are byproducts of the interaction between both.
Right. So, in even just keeping that in mind, also, I know that, a lot of times, for the audience sake also, sometimes given how much overcomplication happens in this space, people do tend to break down and, come up with these kind of concepts to better understand. But could you tell us a little bit more, from all the work that you've done over the years as well, that, sort of how does our brain change over our lifespan, and how does that impact, mental health and mental illnesses as well?
I could, Vedika, but I'm a little hesitant. For one, it won't be very relevant to the context of our conversation today. And second, which is the bigger sin, is I'll end up boring everybody. So let's not get into those details. Of course, the brain ages with time. Everything ages over time. We see our hands age. We see our faces age. We see our knees age. The back ages. We all age. All the organs age. It's not surprising, therefore, that the brain ages. I mean, one indication of that, and I can say that I kind of have a bit of that too. I've started forgetting names of people. I do remember other details, but I have lately become somewhat forgetful, which, of course, thank God, is age appropriate and not beyond. So the brain ages in all of us. And, it has been said that our brain is at its peak at the age of 24. At 24, 25, in our mid-20s, our brain is at its peak. Thereafter, it's on decline mode from the age of 25. But because the capacity of the brain is so huge, we don't feel that decline as a result of neuronal fallout until we have crossed our 60s. And in some, I have seen, they're uniquely blessed. In their 90s, they are as sharp as ever. So yes, there are changes in the brain, but there are different rates for different people. And there too, to come back again to what you alluded to earlier, both nature and nurture play a role.
Right. So also, since a lot of times there's this entire notion of, where people view the mind and body as two different entities, almost like a dichotomy between the two of them. But what we don't realize is that a lot of times that, poor mental health or mental illnesses can have physical health implications as well. So could
Absolutely,
you...
both ways, Vedika. Both ways. I think people have more or less understood now. We all talk about it, that, when people are stressed, their immunity comes down. When people are low, they get body aches. In fact, in Eastern cultures for a long time, there is a concept of somatization, sometimes ironically called smiling depression. These are people who experience physical symptoms of depression, fatigue, listlessness, pains, and yet they do not necessarily experience the mental equivalents. In fact, these are called depressive equivalents. The point is they do respond to antidepressants dramatically, the physical symptoms. When we're anxious, we've all been anxious at some time or the other. You feel butterflies in the stomach, feel lightheaded, palpitations, sweatiness. So that is quite well known. But now what is also emerging is the other way around. The body influences the brain. If you're not in good health, that can affect the brain, of course. And now there is, and that kind of tells us about this mind-body integration. Lately, the gut biome, all the bacteria in the gut, as I'm sure you're aware, the good bacteria and the bad bacteria connect with the brain through the neurons. So sometimes clearing up the gut with proper treatment helps people to come out of depression. I'm not saying it happens all the time, but there is tremendous interaction with between the body and the mind. In fact, it is one unit again. We don't need the dichotomy. You know, Rene Descartes is sometimes, I think, unjustifiably blamed for his Cartesian view, you know, the x-axis and the y-axis. And while it does make a lot of sense mathematically to have those coordinates, they certainly help in navigation. But to stretch that Cartesian dichotomy into everything doesn't always help us.
Right. Like for instance, that very often, people with depression complain that they have migraines. For instance,
Yes.
so how do you know? How would somebody know? For someone who's watching this right now, like since we're talking about, okay, mental health is very much in your brain. How do they know whether they need to go to a neurologist or a psychiatrist, or if they have the ideal combination like you, a neuropsychiatrist? Like, how do they know where they need to go?
Vedika, first thing we need to know as people in the helping profession, and you're one of them, is that the cardinal rule is to empathize. So if you or I had a severe migraine and it was hurting us, what would we want first? Do we want to be told who to go to? Do we want to be told that this could be psychological or this could be want relief? You want immediate relief. So the first thing they need is symptomatic relief. Mind you, it's not a cure, but it's symptomatic relief. Sometimes the things are very, very simple, not always so, but very simple. Closed, dark room to lie down in it for a few minutes. For some people, coffee works. There are various home remedies which can be tried. It is important for the person to figure out what the triggers are. But I guess you use migraine as an example. You're not asking me what do you do for somebody.
No.
But if somebody is going through any physical symptoms, you need to first work out a way to give that person symptomatic relief. And in that sense, migraine is a good example because almost everybody has experienced a headache at some time or the other. Now, if I have a headache and you tell me, okay, Dr. Parikh, let me try and understand what your childhood was like. And, have you had these symptoms? My headache is going to get worse. It's not going to go down. So I think we need to relieve that. It could be just a crocin, for example. And then when we have the luxury of time and the other person has some relief, that's the time to go into what came first. And sometimes we don't know. But if we recognize that it's a vicious cycle, the migraine can make somebody depressed. And that's what usually people will say that, oh, if you tell them, are you depressed? Of course, wouldn't you be depressed if you had a migraine like mine? So what came first? Did the depression come first? Did the migraine come first? Did both come together? These are academic questions. They're important, undoubtedly important for research. But in the real world, we need to empathize with people, give them relief, and then get on to a way of preventing them, ideally without any medication.
Right. So in that sense, how would you distinguish the role, of like the neurologist from the psychiatrist? Because people may not know where to start.
They could start either ways. They could start a good psychiatrist will know what his limitations are. So will a good neurologist. And in an ideal scenario, neurologists and psychiatrists work together. So for example, in the mid-80s, when I had my training, I trained for 2 years in psychiatry, 2 years in neurology. And it was a combination of both experiences, which enabled me to be a neuropsychiatrist. Now, of course, not everybody has access to a neuropsychiatrist, so they could go to either. It doesn't really matter. Actually, the ideal first stop may even be their family doctor, if it is something like migraine. Of course, if it's something which is more nuanced, more complicated, then they need to make a choice.
Right. So often also we don't talk about, how several mental disorders have very high mortality rates. So,
True.
could you tell us, why is that the case?
I'm not sure we know fully why. We do have some conjectures, but what you're saying is absolutely true. Whether not just mortality rates, but even recovery rates. Recovery rates from physical illnesses are more depressed. We did a landmark paper, it is the first paper of its kind in the world. We published it in JAMA, the Journal of the American Medical Association, if I remember right, sometime in the late 80s. And what we did is we matched two groups of patients who had post-stroke depression, okay, or rather who had lesions, similar lesions in the brain. One group was depressed, the other was not. But in every other way, they were comparable in terms of the degree of physical impairment, in terms of the size of the stroke, the more or less the location of the stroke, not always the location. But these were comparable groups of people who were physically impaired, age matched, gender matched, left right handed matched in every way. So when we were matching in everything, the numbers shrunk, of course. But what we found is that people who were depressed did not recover as well as people who were not depressed at the end of 2 years. So depression following stroke impacted physical recovery. This has been seen time and again. And, sometimes when you chat with doctors, they'll tell you that they can tell in the first 2 weeks which patients are going to recover faster and which are not. And the patients who are cheerful or optimistic, they're the ones who recover. And sadly, the ones who are depressed don't. So even on physical recovery, there's an impact. And therefore, not surprisingly, there's impact on stroke. So there was another study which was done. I was not part of that study. It was conducted after I left, but used the data that I had collected. The data that I had collected. Then over 20, 30 years, some of these patients did not survive. Now they looked at mortality rates in post-stroke patients, and they found the ones who were depressed, they died earlier than the ones who were not. So this is the area I work, but in all other areas, heart disease, etc. As I said, we don't know the exact reasons why, but depression clearly impacts recovery and mortality.
I know, linked to this, again, I might be simplifying it, but, we did see that in a lot of Western countries, there was a lot of advocacy that, people with mental illnesses should be considered to be high risk and should be given vaccinations as a priority group.
Yes.
And I think there was a lot of that in India as well. There were a lot of people who felt that, that people with anxiety disorders or depression should be considered high risk and vaccinated first because they might, be more susceptible to picking up the virus.
You're not oversimplifying at all. There's no oversimplification, Vedika. I would go a step further. We're all high risk. Whoever is not vaccinated is high risk. And mind you, they're not just high risk for themselves. They do not realize they're high risk for their families, for the elders in their families, and for society as large. So, in our second book, which became a national bestseller, the one on vaccination, and, as you pointed out, we wrote that even before vaccination started, that, everybody should get vaccinated. I'm a great proponent of vaccination. I have, of course, been vaccinated. I've had my boosters twice. I think it's not only a service to ourselves, but to society at large.
Right. But, why do you feel, how does this tie in with the whole, that people with mental health conditions should be considered a priority group for vaccines and boosters?
They should, because what has clearly been documented, not necessarily in COVID, but for ages before that, in both clinical and laboratory studies, is that depression affects immunity. At the cellular level, if you take blood samples and look at the immunological markers in these people, the cells that defend us, the globulins that defend us, there's a difference. When people are not even depressed, people are stressed. Stress affects immunity. And I think if we look back, we will all remember a time when we were stressed and then we got the flu. So you see it all around you, that stress does affect our immunity. And so it makes sense to bolster that immunity with vaccination, particularly in people who are depressed. Then there's another factor. Sometimes people are so depressed that they do not have the enthusiasm, the zest for life, the joie de vivre, and they've given up. So they don't really care. They're beyond vaccinations. Okay, whatever comes, let it come. And then you need to encourage these people, because they're not taking vaccination may be yet another symptom of the depression. And that too may make them vulnerable. Then they may also be extra vulnerable in not taking adequate precautions against the virus. So yes, in that sense, they do pose a fairly high risk.
Yeah, I was just going to come to that. There are a lot of times people with poor mental health or, who might have more serious mental illnesses will not look after their own selves. So personal hygiene might be compromised. They may not wear masks and they may not be, like hand washing and sanitizing as much as they should be.
Absolutely, Vedika. You're right, bang on.
Well, moving forward, there's a lot of stigma, unfortunately, which still exists around medication for mental health conditions. Like, we would never shame someone who's taking diabetes medicine or, a BP medication, that you're not going to pill shame them and be like, why are you taking this, or you don't need to take this. But we still see a lot of that when it comes to mental health conditions. But there will be people who need, pills to make their brain work better, and that's perfectly fine. But how do you feel, we can counter that stigma, and, what are some myths around medication for mental health that, you would like to call out?
Okay, now let's get to the myths first. First is that medicines make you dependent, that you'll be taking medicines all your life. It's a complete myth. Most of my patients, the vast majority, I would say, maybe as close to 90%, 85 to 90%, are off their meds in 2 years. Okay, some even lesser. This is the average. So you're not on it. That all these medicines are habit forming. Mm-hmm. Third, that taking medication is a sign of weakness. That means you're not strong enough. You have to take a medicine to get well. So all of these are myths. But having said that, I do respect the right of people to make decisions. I would be the first to emphasize that medicines are not the only approach and should not be necessarily the first approach. Sometimes they could be, but they don't necessarily have to be the first approach. That counseling has a very important role to play, that psychotherapy has an important role to play, particularly in disorders like anxiety, that yoga, meditation, exercise, mindfulness, a lot of other things are important, and sometimes people make the choice. And when they do make the choice, I respect them. I tell them to keep medication as an option. And sometimes you need more than one approach. It's a journey that you take. You don't just take a journey by air. Yeah. You may choose to walk part of the way. You may take a cab to the airport. You may either take a plane or you may prefer to sail. It all depends on multiple factors and individual needs. So while I do advocate that if necessary, one should take medication, I'm the first to admit they're not the only approach. They're not necessarily even the best approach. One has to judiciously decide first whether somebody needs medication or not. When I was a medical student, one of my favorite professors, Dr. Manu Kothari, used to say that a good surgeon is one who knows when not to operate. Mm-hmm. And, I like to tell the students that I trained, and I've trained quite a few in different parts of the world, that a good psychiatrist is one who knows when not to prescribe. Mm-hmm. So I think the message is important on both sides for people like you and I, who are in the helping profession, that we shouldn't go overboard with medication, but also to the people we're trying to help, that do not shy away from medication if required.
I think, as you said, I think it's very important that, we have that balance between, if you need it, it's okay. And there's no shame in taking it, but there are also other options available, and let's be open to seeing, what could help, or possibly, as you said, looking at a combination of options, not just medication, but also certain lifestyle changes.
But there's one other thing, Vedika, and that I just recollected lately. By lately, I mean over the last 10 years. So that's not really lately. At my point in life, it becomes lately, a lot of years. But lately I've been seeing people come demanding medication. They've researched all the stuff on the internet. They've figured out which medication will work best for them. And sometimes they're right, I have to admit, but not always. And they'll come and say, doctor, I know I have depression. I don't want to waste your time. I have done this scale and I'm really moderate to highly depressed, and X drug is the best drug for me because of this reasons. And, if you prescribe it to me, I'm sure I'll get well. Well, I am never critical of this approach. I'm never critical. It's very, very important patients are well informed. Okay. And I say, even that is fine. One of my colleagues will take a detailed, 1.5 hour, 2 hour history. I will go over it with you. We'll see what the options are. And if this medication is a possibility, I'll certainly prescribe it. You know why? Because it's also going to have a placebo effect. The person believes that medicine is going to help them. There's a 30% chance just that thought is going to help them. So if possible, I try to accommodate it. And, I am discovering lately, and particularly in the younger demographic, people your age, they've really researched it. It's not a superficial research. They'll spend hours. Sometimes they'll come with a file full of printouts. And once in a while, I have to admit, every now and then, I'm impressed because, they have come up with something that came up just yesterday, and I might be 2 days or 3 days late in catching up with the literature. And then I am honest enough to admit that, wow, you printed this out yesterday. I didn't read the journal yet. I will read it. If you don't mind, come back after a week. And once I have caught up with you, we will settle our discussion. That too happens.
I think it's very interesting that, you brought up this whole aspect of, like self-researching, and, sometimes you've seen that there's this competition. It's almost like Dr. Google. But what are the dangers almost of this, because as you said, I've seen it a lot myself, where the younger generation has researched, they use very clinical language when they're talking about their problem. But sometimes do you feel that they're, again, oversimplifying what they're doing, like feeling, that somewhere we've over-medicalized mental illness?
Yeah, they might, but so do we. We're equally guilty of that. And where do we get our knowledge from? I can't now buy books and keep reading them. I would, if I bought a book and start reading the book, I'd be at least 2 years behind the literature. So I am also going to Dr. Google in a sense, except it's PubMed or except it's the New England Journal of Medicine, the Lancet, and Nature or whatever. But I'm also reading off the net. So who am I to decide that I can take my knowledge of the net, but you cannot? It's like, I'm taking you back in history, but I'm a student of history, so you'll have to pardon me this excursion. But when Gutenberg, invented the moving type, when the printing press started, it liberated people because everybody was ignorant and power was concentrated in a few who passed it from generation to generation and deprived the others and therefore retained a tremendous control over their lives. The printed word freed people. Now people were free to read newspapers, magazines, all of that was available. Yes, there was a negative side to it, but it's enormously outweighed by the good. And so also I believe about the internet. So also I believe about Google. It has benefited us, all of us, me included, far, far more than it has caused harm. Now, anything in excess is going to cause harm. If you just keep randomly crossing the road up, down, going nowhere, sooner or later you're going to get hit. People, have a sip or two of wine, enjoy a glass of wine. It can enhance the flavor of their food. If they just keep doing it all the time, it's going to take a toll. But because some people do it in excess and perhaps injudiciously, we can't blame the tool. You don't blame the knife. You blame the person who wields it. And yes, we must understand, we must empathize, Vedika. People are anxious. And sometimes they put it to good use. As I told you, I have young kids come up to me with something that appeared in the journal yesterday, which I have not yet read. So I have to appreciate it. I have to admire them for it. And sometimes I even thank them for bringing it to my attention.
Right.
I think let's be open about it. I think this wholesale condemnation, again, there we're doing the same thing. We're, giving names, WhatsApp University and stuff like that to condemn people's information. WhatsApp has played an enormous role during the pandemic. Of course, it's caused an infodemic also, which is a secondary problem. But I think with all things, we have to weigh what is useful and what is not, and generally veer ourselves gently but surely in the direction of what is helpful.
Right. You mentioned that, sometimes with the way literature and information is changing, sometimes that, you find that, you get left behind. And we've seen that there are a lot of new terms which have come up, right? Either there have been new conditions which are being diagnosed, such as you've got, I think, complex post-traumatic stress disorder. You've got now I think it's PGD, right? Prolonged grief disorder has come up in the new DSM as well. And at the same time, we're also having a renaming of a lot of disorders. So I think BPD is now emotionally unstable personality disorder. So how do you think that somehow affects, the knowledge and the perceptions that people have? And also for you, like in your work, do you feel that
Vedika, let me make a disclosure in the beginning. I'm an eternal optimist. Okay, by temperament, I'm an optimist. I see good in most things, and almost everything I see some good. As knowledge evolves, naturally nomenclature will also evolve. To give you an example, The Inuit Eskimos, I believed until recently, had only one word for anything that flies. So whether it's a bird or a plane, helicopter, anything, there was just one word for any object that went through the sky. But they had about 60 different words for ice. Depending on the consistency of the ice, the texture of the ice, the hardness of the ice, how quickly it melts, they're different words because that's their world. So, they won't say ice, they'll give you 50 different words for ice. So as knowledge develops, our naming of words, our renaming, it all progresses. And I watch it with interest because I want to learn. I'll give you an example. When our daughter Nikki was just 3 or 4 years old, we used to play word games. I was trying to get her to improve her vocabulary. She already had a great vocabulary, but I was trying to enhance it. But I was also fascinated by the things that the new language that she was doing with her friends on cell phones. So I told her, well, I'll teach you 5 new words every day, but you have to teach me 5 new words. So she taught me a word in those days. Now, of course, it may have even fallen out of fashion, but which was GTG. She would write to her friends GTG. So I would ask, what does GTG mean? She said, it's got to go. I said, okay. She said, what does it mean? She said, it can mean 5 different things. Got to go means my dad and mom are around and I cannot talk to you anymore. Okay. Got to go means I'm in a rush. Got to go means I'm bored. So I was fascinated. I said, this is such efficient use of language. In 3 letters, you're communicating quickly to somebody your age. Oh, host of them. I asked her, how will she know which of these things matter? She said, oh, she'll know. She'll know whether GTG is because dad is around, I can't talk to you, or GTG is because I'm bored, or what. So there's a context, there's a nuance. So I am really amazed and, I'm fascinated. I mean, look at language. If you look at the evolution of language 5,000 years ago, it started with hieroglyphics. There was signs, and even today, even the Chinese and the Japanese alphabet is a large number of hieroglyphics. But our language evolved to such a degree. And now what are we finding? We look at these emojis, and one emoji is conveying so much to another person who understands it. So language is evolving, nomenclature is evolving, and we can't stop it. Okay, as Bob Dylan sang, a long time ago, the times they are changing. I mean, in simple words, you got to go with the flow, right? Okay. So I'm picking up the words, but anyway.
So we're talking about times changing. We're having a lot of conversations about the new normal as well. So in terms of mental health and the way perceptions change, what is something you'd like to see more of?
Oh, I'd love to see change. I'd love to see change. I'd love to see young people like you doing the kind of work that you're doing, because this is something we could not do. We either didn't have the talent for it, or we didn't have the knowledge for it, or most certainly we didn't have the tools for it. And so I'm excited. Until 3 years ago, I didn't own a cell phone. My children convinced me to start using a cell phone, and I think they, in their own way, simplified it for me and said, Dad, think of it as a computer that you have in your pocket. You can check your emails. So they sold me on the idea. And I did finally get a cell phone. That was about 6 months before the pandemic. And what a boon it's been through the pandemic.
Mm-hmm.
So I get excited by new tools, new things that are coming. I am sometimes resistant to. I shouldn't take full credit for it. I mean, the flip side of not having a cell phone, all these years is also there. But it enabled me to write, to think, to have conversations without interruptions. So in my lifestyle, one without a cell phone was fine. But when it became necessary, luckily just before it, I had it. So I'm very excited about the work that people like you are doing.
Well, that's very kind of you. You've been really supportive, and just, to sort of bring things towards conclusion to everything that we spoke about. We spoke a lot about the biological aspect of mental health. So how do you feel that, things like, let's say, our sleeping patterns or our eating habits or even our lifestyle choices in that sense impact our mental health as well as, play a role towards mental illness or can exacerbate mental illnesses?
I'm a firm believer in it, not just from the literature that I have read, but also from my personal experiences. So, for the longest time from childhood, I just needed a very low sleep requirement. I sleep for 4 hours, 4.5 hours through most of my life. And then as I grew older and I read more about the effects of sleep on health, and there's a huge body of literature. Now that's a discipline in itself, sleep. But a body of literature of the impact of, reduced sleep on health and particularly mental health in the context of what we're talking. So I gradually increased my sleeping time and now try to sleep 7 hours a day. But I have noticed that on days when I sleep less, I'm forgetful. I become slightly irritable, which I like not to be most of the time, at least. And I do find changes. I experience it. Likewise with food. So yes, both in my personal experience and in the stories I hear from my patients and my colleagues. Remember, I learn as much from my patients as I am able to help them. Sometimes I learn even more fascinating stories from my patients. So in all of that, and of course the literature, the academic literature, above all, it's the data. All clearly indicates what you're saying, that sleep, appetite, lifestyle, our close personal relationships, our social connectivity, all of that plays an important role in our health. And by the way, just 2 days ago, I read an amazing National Geographic cover story on social connectivity and health. I would recommend it to all. If you can get the issue, nothing like holding it in your hands. I'm old-fashioned, of course, but even online, it's a neat encapsulation of the issue that you raised and would speak more eloquently than anything that I could possibly tell you in a few minutes.
No, but thank you for that. And I want to ask you that, are there any parting words that you would have to anybody who's watching or listening to this right now who could be having a hard time with their mental health?
Oh, I am not a sage, Vedika. You make me out to be some kind of a prophet, which I am not. So what does one say? Let's all work together. We need to do this together. Okay. And please do not look upon a mental health profession purely as a caregiver. We like to call ourselves caregivers, but I think we are participants in the same voyage. And some of the people who are going through this should also understand that there are a lot of people, particularly post-pandemic. Okay, a lot of people have gone through it. Even some of the people who helped you are going through it. I have experienced prolonged grief in my life when I lost my mother, and I was not around at that time. I was in the US, and the closure took a while. We've all gone through what you're going through. Of course, perhaps not to the amplitude and the duration that you're going through, but there is a way out. There is always a good and a healthy way out, and we can work in it together. So you have to be an active participant in your care. Forget what they tell you about Dr. Google. Go to Dr. Google. Go to the internet. Read about it. Read the stories. But with a caveat, the internet is a free for all. So just be mindful of the sources that you read. Talk to people. People like Vedika, people like me. We're there for you. Have a conversation with us. But get started. It's a wonderful, bright world. And life is too short. We must try to enjoy every possible minute.
Thank you so much for that. And, Dr. Parikh, thank you for your time and all the insights that you shared. I think it's been very enriching. And I'm sure people are going to draw a lot of hope from this, but also a lot of learning that, there is, help out there. There's hope out there. So anyone who's having a hard time, know that it gets better. You're not alone in this. Somewhere, as even you said, Dr. Parikh, we've all got COVID has sort of given us a common lived experience. So, just reach out for help and it gets better.
Vedika, you gave the best parting words. You asked me, but your answer was the best. You're not alone in this. It's 5 words. 5 words, I think they summarize it. You're not alone in this. It's been marvelous chatting with you. Thank you for having me on your program.
Thank you. And so till next time, please stay well and stay healthy. Thank you.